the cloud.
Okay. Now, we have a microphone for you too. You can have this one. The trick on these is to try and hold it up close.
Sounds good.
So with that, I give you Dr. Dorfman, and maybe can you give us some insight into why you're doing this?
Yeah, so my name is Ben Dorfman. I'm a movement disorder specialist with Hartford Healthcare. The Chase Family Movement Disorder Center is the name for the movement disorders wing of that health system that we have. I first got interested in this field somewhat serendipitously right after college. So I was studying neuroscience in college at Johns Hopkins, and I was sort of on a track to go into a neurosurgical field. I had done some sort of neuro-oncology, neurosurgical research, had a job slated at Weill Cornell, which would have been a perfect transition for that. That got pulled out from under me after about a month of no thinking that I had it. But they passed my resume along to the movement disorders division. So it was really pure coincidence that I ended up in that field. But then I was really there and I found my passion. I worked there for 2 years. I was a research assistant working on clinical trials. Met a bunch of mentors that I'm still in contact with who sort of got me interested in the field. And when I went to medical school, I tried to branch out. I tried to say, okay, that was fun. Put it from your mind. Try to try other things. Maybe I'll be a primary care doctor. And I was the president of the family medicine interest group and primary care progress, and I just couldn't get away from neurology. I came right back to the movement disorders. So, in spite of trying to branch out, I ended up with my original passion.
Terrific. I'm glad you did. So you are not only a neurologist, you are a movement disorder specialist. Can you tell us a little bit about that extra training that a neurologist needs in order to have that specialty?
Yeah, the distinction between sort of movement disorders as a specialty and general neurology has not been around all that long. Really, that came to the forefront in the 80s. And there weren't even fellowships at that time. But as time went on, this became something that people were able to be specialized in. Fellowship programs did develop where after residency, you can opt into doing additional training to specialize within neurology in a field if you're interested in that, movement disorders being one of them. And there are about 50 fellowships in the country. And that's something that I was pretty confident that I wanted to do after making my mind up that I wanted to do movement disorders long term. And then so the rest is history.
Well, we have a group here that is very interested in knowing more about some of your knowledge. And 19 questions came at me. So can I go down the list a little bit?
Yeah.
Okay, I know some of us come to see you already. And the group is interested in some of the creative uses of medication that some have found very helpful. For example, Crexont, if I pronounce this right, Ongentys,
Yeah.
Ongentys and modafinil. Would you speak to those three medications and some of what that can provide as benefit?
So Crexont, I will admit, even feeling that I didn't feel Crexont was going to be a medicine I would use very much when it first came out. Crexont is carbidopa levodopa. And just to back up, when you think about the list of medications available, symptomatic treatments for Parkinson's disease, I think the list is at least 60 different medications long. Some of those have since no longer being produced, but there's a decently long list of different medications. But if you look a little bit more closely, half of them are carbidopa levodopa. So that can be a little discouraging to say, well, okay, well, are there really that many different medications out there if they're all carbidopa levodopa? And yet I think that it still is significant that we have these different versions of carbidopa levodopa, and that's what Crexont is. Crexont is a new brand name carbidopa levodopa. And Crexont itself is even more derivative than that. It's a updated, upgraded version of another brand name carbidopa levodopa, but one that is has some advantages over generic carbidopa levodopa. So what it is a capsule containing little beads of a combination of both immediate release, sort of quick delivery carbidopa levodopa, in addition to three different versions of a slow release carbidopa levodopa. They're trying to build a better mousetrap. So regular generic carbidopa levodopa is rather simple. It's a chalk pill. You take your pill, it delivers its payload as fast as possible, and so it's supposed to kick in quickly, but also can't really linger all that long. And over time, if you end up needing more of it, your options are to just take more frequently or take more of it. With Crexont, because it has that combination of the different components, as well as the specific way that they make the extended release, be it these multiple different proprietary coatings they put on the beads, one to make it stick in your gut longer, one to prevent how quickly it gets broken down, one that is a sort of an extended release component of its own. It allows it to sustain itself longer and be more of a square wave as opposed to just being up and down quickly. So I think the main thing people think about as an advantage to that is, well, hopefully that means that the medicine will last longer. Maybe they don't have to take it quite as long. And that is true. People are able to get longer duration out of it. And often that means they can take the medicine less frequently. With generic carbidopa levodopa, it's pretty rare that somebody can actually get away with taking the pill less frequently than 3 times a day minimum. Sometimes 4 times a day, 5 times a day, more. Crexont's the first that I've seen of carbidopa levodopa where some people get away with twice a day. Which is nice. Not everyone's going to be able to do twice a day, but it is possible with that medicine. And the other thing that I like about it that I don't think they advertise quite as heavily is that in addition to not spiking as much and or not lasting longer, that with it not spiking quite as much, it means that it's less likely to cause side effects sometimes. So some of those side effects people can get are from that quick spike that you get from the immediate release. Whereas if it's the sustained release, if it doesn't spike as much, you maybe won't have as much dizziness or nausea or low blood pressure, fatigue, those sorts of things. So I think that's a medicine that has some advantages to it. Now, Rytary was rather similar to Crexont. That was sort of the predecessor. They still make Rytary. The problem with Rytary is very few insurance companies covered Rytary, and it didn't have some additional little updates that they did with Crexont. So I think Crexont's a little better than Rytary, but I don't think it's dramatically better. But it's way better covered by insurance. So that's one of the things that that got my attention about it. It wasn't that I thought it was going to be so dramatically better than Rytary. The other good thing is that with the ability to try it more than Rytary, I do feel like there are some advantages. I think that there are some people who never really got the benefit they wanted from generic carbidopa levodopa, and then Rytary or a Crexont was able to work better in ways that the original couldn't, both Rytary and generic.
Thank you. Any specific questions about that? Okay, let's go to the next. It's Ongentys.
Ongentys, another one that at face value doesn't sound really all that different from the old fashions, but it's not a carbidopa levodopa. It's what's called a COMT inhibitor, and that's used as an adjunctive medication. You take it with carbidopa levodopa to boost the effectiveness of the carbidopa levodopa. That's not a unique idea. There was another medicine on the market called entacapone that does the same thing. With entacapone, you had to take a dose with each dose of carbidopa levodopa to see any benefit. Ongentys is different because it's a 24-hour once nightly pill, or capsule, I should say. And it wouldn't sound like that would make a difference if it does a similar thing. In practice, we have seen that there are some people who do get better response from the Ongentys than they did from the entacapone, to say nothing of the convenience. Another medicine that when it first came out, well, that all sounds nice, but insurance won't cover it. We have a much better time getting it covered by insurance nowadays, so we're actually able to play with it in ways we couldn't before. And that's the case for a lot of these medicines, that when they came out, they were attractive ideas, but as they've gotten a little more established in the market over the past 5 years or so, we're able to use them more regularly.
Thank you. The third one was modafinil, I guess also called Provigil.
Mm-hmm. Yeah, modafinil is a generic medication, and what it is it's a stimulant. And this is a medicine that has some evidence. It's not, I think, extraordinarily commonly used, but it has some evidence that it can help with energy for a variety of conditions. Actually, I think more commonly used for narcolepsy. but it's also used off-label for people who have low energy, and particularly in Parkinson's disease. Similarly, there's some people who've seen similar effects from Adderall, another stimulant, maybe a little bit more of a household name. I think modafinil has a little more evidence behind it. And the biggest problem with modafinil, besides sometimes insurance companies don't want to cover it, is there's a little bit of a risk to putting someone on stimulants. If you have cardiac risks, we get a little nervous about putting somebody on a stimulant. If you have a history of heart attacks or arrhythmias, I think cardiologists may give us a hard time about considering that medication. But if someone who doesn't have cardiac risk factors, sometimes it can be a really helpful medication. Besides, sort of cardiac risks and risk of sort of raising blood pressure. If someone has a problem with insomnia, sometimes I worry about it, but the goal is to take the pill in the morning to help with energy during the day. But there are still some people who may get insomnia in the evening. Just try to keep it as far away from bedtime as possible.
Thank you. So those were 3 medications that were asked about. One or a couple of people actually asked about the DAT scan and when that might be advisable. The DAT scan?
Yeah, the DAT scan is a diagnostic test. Diagnostic test used for looking for evidence of Parkinson's disease and related conditions. It's been out since about 2015, I want to say. Actually, no, it's maybe longer than maybe 2011 or so. That we first started hearing about it. So it's not really new information. It's been out. It's more widely available now than it was when it first came out. It's a nuclear medicine scan, a PET CT SPECT scan, and its purpose is to look for objective evidence of problems with dopamine production. So that's useful information to look for if you're considering a diagnosis of a Parkinsonian condition. It's particularly useful when you're trying to distinguish between something that causes Parkinson's symptoms but is very different from Parkinson's disease. For example, someone who has a tremor and it looks a little in between garden variety essential tremor or Parkinson's disease. Because if someone has a lot of tremor at rest, but they don't have other Parkinson's signs, makes you think, well, it could go either way. Because it's a test that looks for that problem with dopamine production that's unique to Parkinsonian conditions. If someone has essential tremor, the expectation is the test will be normal. Whereas if someone has a Parkinsonian process, it'll show a problem with dopamine production. Similarly, people can sometimes develop Parkinson's symptoms as a side effect of medications, particularly psychiatric medications, schizophrenia medications, bipolar medications. They can look just like Parkinson's disease. That's called drug-induced Parkinsonism. And it's important to know that distinction rather than diagnosing someone with this permanent disease. What if we just got you off of those medicines? Maybe you'd go back to normal. So DAT scan is useful for that. If you send somebody who has every Parkinson sign under the world, but they're also on haloperidol, if you send them for DAT scan and it's normal, then the focus should really be on the drug rather than on Parkinson's disease. One of the limitations of the DAT scan, it doesn't distinguish between things within that family of Parkinsonian conditions, because Parkinson's disease is not the only condition in that family. There's that Lewy body disease, or some of the atypical Parkinsonisms like multiple systems atrophy and PSP and corticobasal syndrome. And all of those do involve reduction in dopamine production, and they'll all show up positive on a DAT scan. And that's one of the things that the reports from a DAT scan now say. They say there is some evidence of some kind of Parkinsonian process, but we can't tell more beyond that. So I think it's useful for these borderline cases. I don't use it very often for someone who has really classic presentation of Parkinson's. They respond to Parkinson's medicine. If we didn't have this scan from the past 20 years, we wouldn't have had that option. We would have just proceeded ahead without it. I think it's useful for the borderline cases when there's still some question about clarifying the diagnosis.
Thank you. Any questions on that? Back there, Kathleen?
It shows, that scan shows a problem with dopamine production. It guarantees Parkinsonism. It can't be something else.
That's a good question. How accurate is that test? Pretty good. 85%. That's good, not great. And there are confounders. There are things that can throw off that accuracy. If you were taking certain medications, you're supposed to hold certain medications on the list that can throw off the accuracy, but also sometimes people forget or the message doesn't get through. Sometimes there are structural changes in the brain that can throw off the accuracy, usually causing false positives. If you have stroke in just the area they were looking at, where that tissue is not going to produce normal dopamine anyway, so it can kind of throw off the results. If someone has shrinking of the brain or enlargement of the fluid pockets in the brain, so hydrocephalus, it can actually lead to false positive results. So it's not perfect. It's still useful, but I think we take it with a grain of salt. There's it also goes both ways. There's both false positives and false negatives. In each case, about 85% accurate. So that's where this new test has been helpful as well. It's a new test that's about 5 years old, which is a skin biopsy. And a lot of times we're using that sort of as a confirmatory measure, especially when things are really weird. If we do the test, oh, it looks like this is Parkinson's. Okay, we put you on Parkinson's medicine. Hang on, the medicine's not really doing anything. It's not really behaving like Parkinson's. Let's do the skin biopsy. So it can be useful to confirm those results. And it looks for evidence of Parkinson's in a different way. So instead of looking for problems with dopamine production in the brain, it's a way of actually looking for the Parkinson's protein that builds up in the nerves and actually causes the pathology. You can look for that same protein in the nerves in your skin. So it's just a non-invasive way of looking for Parkinson's disease, much less invasive than a brain biopsy. So sometimes, especially when there are lingering questions, we'll consider the biopsy.
Thank you.
Yes, follow-up question.
Michelle.
Yes, could you talk a little bit about Lewy bodies and how to test for them and what that means that they're found?
Yeah, it's confusing terminology. A Lewy body is a large cluster of a protein or a misfolded protein called alpha-synuclein. So we sometimes use those a little interchangeably. Alpha-synuclein is the protein that we worry about in Parkinson's disease that gets misfolded, and then it has a tendency to clump, and it turns into these fibrils, and the fibrils turn into clumps called Lewy bodies. So it's just a large cluster of alpha-synuclein. But when you get large accumulation of this misfolded protein within your nerve cells, it reduces the efficiency of the nerve and causes it to shut down and die. And so it's both the causative protein that we worry about, and it's also that diagnostic marker we look for to screen for Parkinson's disease. So when I say Lewy body disease, it actually refers to a different diagnosis. The official term is Lewy body dementia or dementia with Lewy bodies. I don't really like that term. In some ways it's accurate because what that condition is a Parkinsonian condition that has more prominent cognitive symptoms, but there are people who are diagnosed with Lewy body dementia who don't have dementia. So I feel like it's not a great term. I think Lewy body disease is maybe a little more gentle. My personal belief is I actually think that Parkinson's disease and Lewy body disease, I think they're probably the same thing, just on a spectrum. Officially, we do distinguish between them. And the dividing line is that if your cognitive symptoms start within the first year of your motor symptoms, we err on the side of Lewy body disease. And if any cognitive symptoms start later, then it's more likely to be Parkinson's disease with cognitive symptoms. I have seen people break the rules left and right. I've seen people who end up having Lewy body disease and it was 13 months instead of 12 months. I think the disease is not smart enough to be easily clumped into those little categories. So that term Lewy body disease is referring to the pathology, but we don't talk about pathology for Parkinson's disease because they didn't know what Lewy bodies were back in Parkinson's day. So I think the terminologies could certainly be improved. That one is a Parkinsonian condition with prominent cognitive symptoms early on, with Lewy bodies present, but Parkinson's has Lewy bodies present too. So it's focusing on what the pathological protein, I think, was a mistake for that condition.
Thank you. So next question. Our meeting last time was on freezing of gait. We had Tricia. Can you put your hand up, Tricia? So Tricia Wyatt, who's an excellent physical therapist with expertise in Parkinson's, led that. And in that conversation, some people said, okay, freezing of gait. Is there also the concept of freezing of speech? A cognitive, I guess, side to that.
There's a lot of good things about what you said, because people will commonly refer to freezing of gait as freezing, and it's true. The official name of that is freezing of gait because that is the most common way that it presents. But it is not the only way that it presents. It is possible to have freezing that isn't freezing of gait, even though that's the official term. So I've seen people have freezing of limbs. So trying to reach for something and they freeze. Less common. Freezing of gait is the most common, but you can have freezing of body movements. You can have freezing of speech due to motor freezing, so physically being unable to move the mouth, but also when someone has sort of a halt in their speech, I think it's harder to lump under the same phenomenon, although it can look the same, but people can also just lose their train of thought. But I think you can have a version of that that is associated with freezing, but it's kind of hard to distinguish between them. I would think we would go about managing those pauses in speech the same way, whether it be motor versus cognitive versus freezing of your cognition. In that the best thing you can do is to not try to push through and just stop and allow yourself to relax and pause to gather your thoughts. You can do something similar when it comes to freezing motor wise, but that we don't have the same kind of visual cues or tricks for cognitive or speech production that we do for walking. We don't have we have that special walker for freezing of gait, but we don't have something similar for cognition. But I think the thing we recommend the most is to try to reduce sort of excessive thinking and anxiety that can provoke that and make it worse, and give yourself a chance to gather your thoughts.
Okay. Thank you. So the next question has to do with care partners. If you're a care partner, can you just hold your hand up and so we have care partners in the room? So what do you look for with a care partner as far as the top things they can do to be helpful for their partner with Parkinson's?
And I was thinking about that question from the perspective of the patients and the care partner, but that's also a team sport too, because we think about how from the patient's perspective we highly emphasize exercise. Care partners are often involved in sort of making that happen, allowing somebody to get to their exercise programs on a regular basis. The same goes for diet. We recommend following the Mediterranean diet is something that patients can do that can help with reducing the progression of Parkinson's disease. And when I know from my personal experience, when my wife wanted to start a diet, she was happy that I agreed to start the diet too, so she wouldn't be alone. And making it easy to adhere to that diet. I thought the thing I think is sort of not always mentioned is just patience. That goes for patients, that goes for caregivers, that there really needs to be patience and grace, because you can end up being counterproductive if it sort of becomes adversarial. There really should be a collaborative nature from patient and caregiver, and just giving each other the space required to accommodate for this disease.
Thank you. Any other care partner questions like that? Okay. So this one, I thought, wow, this is really interesting. I'd not heard of this. Cold water plunges. And I like cold water plunges myself. Can they be helpful for Parkinson's or tremor?
For tremor, I would not say that it's common practice. I think what I was able to find on it is that there are some people who have, or at least there's data out there that there have been found to be increases in dopamine in people's blood samples when they go for a cold plunge. And I think there maybe are some euphoric and rewarding qualities to going for a cold plunge like that. Does that mean it's beneficial for Parkinson's disease? I think that's far from established. And what I worry more about is risks. So I'm not surprised, and this is borne out as well from what people have seen, that when you're uncomfortable, you may shake more. cold water plunges are, for most people find them uncomfortable. Same would be true of excessive heat. Now, that's not a dangerous thing. It's not like it's going to make your tremor worse long term, but any amount of anxiety or physical discomfort or pain, you may shake more. So I wouldn't be surprised if somebody would shake less as both during the cold plunge and after the cold plunge. And the other thing I would worry more about is that a lot of people with Parkinson's disease have some degree of problems with maintaining their automatic functions of their nervous system, their blood pressure, their temperature regulation. And that's something that can get thrown off by sudden changes in temperature. So I would worry about risk of fainting or not so much overheating, but sort of drops in blood pressure as a potential risk of that.
Okay, so no cold plunges today.
I
Okay,
think it would have some risks to it.
okay, thank you. The next question has to do with relationship between Parkinson's and physical pain, like joint pain, back pain. To what extent, as we age, is that pain just from old age? Or how does Parkinson's exacerbate or contribute to that pain?
Yeah, this is controversial. Party line is that Parkinson's doesn't cause pain. And yet if you go on any forum, there's all sorts of people complaining of pain attributed to Parkinson's. So I think we must be missing something. And I think that the pain that we've sort of begrudgingly accepted is most likely to be attributable to Parkinson's is sort of muscle pain, sort of diffuse muscle pain in large muscles and large muscles of the arms, biceps, and in legs, the thighs, the hamstrings, the quads. And we think of it as it shouldn't be that it's painful, but it's uncontrolled stiffness causing you to feel uncomfortable, potato. I think, it's naive to say that it couldn't cause pain. I think we're probably missing the boat on that. That said, pain is such a non-specific thing. If anybody has any other kind of potential pain generators, we're always looking at that first, especially if it's joint pain or sort of it has classic features that sound like another kind of a pain syndrome. But it gets really tricky when someone says, I have back pain and they have Parkinson's and they also have an ugly looking spine. We're so tempted to say this has got to be the spine, especially if it has features that are classic for that. And yet I think we're not always right about that either. That's where it's helpful to pay attention to the little details. If we get these data points that, yes, I have this back pain, and in some ways it sounds just like the kind of pain you get from your spine, but every time I take 2 tablets of levodopa, it stops in its tracks. That doesn't make sense. You wouldn't get that from spinal degenerative disease. If we get these little clues that say maybe there's some superimposed rigidity that's sort of compounded on top of the more garden variety arthritic pain, be it in the back or in the joints, I think we can't discount that. Although more often than not, we're not expecting that more Parkinson's treatment is going to be the answer for the pain. But if it does, you can't ignore that.
Thank you. Taking of the Parkinson's medication, carbidopa, levodopa, etc. We talk about needing to have it within a fairly narrow window of time. Can you talk about how important that is and how flexible it might be or not?
This is also, I don't know if it's sort of controversial among movement disorder specialists, but I do know that there are different providers with different opinions on this. My answer is usually that it's probably not as restrictive as you think, unless it is. It sounds like Yogi Berra. But for most people, I've seen people overthink it. And if you play with it a little bit and there aren't any consequences, you're probably not doing yourself any harm. It's where people feel like the medicine is not performing to its full potential that really tightening things up can make a difference. Not that you want to wait until you get into trouble before sort of adhering to better practices, but that whole 3 times a day rule, I do believe in that. I think the vast majority of people are not going to get sufficient control with less than 3 times a day. There are some people who start with 4 times a day. I think that that's unnecessary. For some people that may be preferable, that may be necessary. I know how I was trained is we would rather just stick with the 3 times a day schedule and just increase more for those different doses. I agree that taking the medicine at the same time each day consistently is going to give you more consistent results than someone who takes, I took it 2 hours later yesterday and then 3 hours later the next day. And sort of, if it's all over the place, I'm less surprised when the results are not equal from day to day to day. There's too much variability there. I think a medicine like Crexon or Rytary is more forgiving in that manner. So that's actually been a reason why some people have asked to switch to Crexon, is so that they can be a little bit more flexible with timing. So I can think of one case where there's a woman who father's home by himself and she's worried about him remembering to take the medicines on a regular schedule and sort of missing doses. And when he was switched to Crexont, he was able to get by with twice a day dosing and didn't really matter. He didn't have to think of taking a midday dose, whether he took the dose an hour earlier or later. He didn't feel those changes anymore. So that was a case where sort of that version of the medicine helped with that problem. We're going to have a question later about sort of relation to meals and things too. So I think that kind of dovetails with this too. That's another area where there are strong opinions about this that actually may not be as important as websites say, but for some people they are real. There's a lot of variability in Parkinson's. So this idea about, can you take the pill with food or should you not take the pill with food? People who see me will frequently hear me say, take the pill with food, but the website says don't. The concern about taking the pill with food is that there's a small subset of the population who, when they take levodopa at the same time as a meal, specifically a meal that's high in protein, that the protein will interfere and impede the levodopa from getting into the brain. And as a result, you won't feel as much potency from the pill. Shakier after that. Why was it so shaky? Whereas if they had a low protein meal, it wouldn't have the same effect. It is true that there is a transporter that brings the levodopa out of the blood into the brain across the blood-brain barrier. And it's the same one that will bring dietary protein. So if you load up on steak and eggs at the same time as your pill, it's possible you could feel not quite as much response to the pill. It's not that often we actually see that problem. Everyone has that potential, but about 4% of the population actually feels a difference. But there are a lot of people out there who are restructuring their lives out of concern about sort of, I'm worried about the protein effect. I'm just going to cut out protein out of my life. I'm just going to eat my meals, just one huge meal in the morning and just don't eat for the rest of the day. I'm really worried about that food interaction. So I tell most people, don't worry about it unless you notice that actually happens to you. Some people it does. I don't see it that often. And if it is the case for you, then pay attention to it. There is some advantage to trying to space out when you take your food, your medicine from when you take your food. And this is for levodopa specifically, not for sort of these adjunctive medicines. The rule of thumb is usually take it 30 minutes before your meal or an hour after the meal. There are some people who find they have to be even more separate than that, an hour before, 2 hours after. For most people, it's to some degree, not a huge degree. That gets a little bit trickier. Some people take pills 5 times a day, 6 times a day, and that gets much more complicated. So that's where some of these newer treatments that have come out have been attractive for that problem. So there are these ways of getting medicine into the body that don't involve your GI tract. There are a couple new entrees into the market that fit that bill. So they're continuous delivery of medication subcutaneously through a pump. And one of the things that they boast is that they're a way of getting Parkinson's medicine without taking a pill. It goes through your skin, through a tiny little plastic tube. So those are pretty cutting edge. They came out about 2 years ago. But for people who have really bad problems with the food interacting with their pills, some people find that a real help to instead take it through the skin.
Thank you. Next question. Dementia. How frequently does it accompany Parkinson's, and is there anything we can do to slow that occurrence?
So cognitive symptoms, I would say, are common in Parkinson's. I talked about Lewy body disease, Lewy body dementia, and saying that if your cognitive symptoms start early in the course of the disease, if we're worried about Lewy body dementia, there are times when sometimes it could be a bit of a red herring that there were some cognitive concerns, but they really weren't so much to the point where we should have been thinking about dementia, and maybe they were just within a more typical range of what someone could see either with age or with early Parkinson's, but we commonly see some degree of cognitive change. 90% of people with Parkinson's will have some kind of cognitive change, so that's rather common. But the minority of those people will have dementia. So there's a wide range. Some people will go on to progress to dementia, but that's the minority.
Okay, thank you. Any questions about that? Okay. Continuing to move to the questions. Someone asks, how can cannabis possibly help someone with Parkinson's?
I think cannabis and the different ways you can get cannabis are a little underused in Parkinson's. And of course, you shouldn't equate THC and CBD. I think THC has a lot of similar benefits to CBD with a little bit of additional risk, whereas CBD, I think, is a safer drug, and we should probably be considering CBD sort of before some of the prescription drugs we use for the things it can be helpful for. It's not a very potent medicine, but I think it's pretty benign at low doses. So the things we've seen benefit for CBD are anxiety, pain, sleep problems, and some people have seen some benefit for tremor, and we don't think it's actually acting on tremor. We think it's really acting on anxiety, and because tremor is so closely linked to anxiety, that anxiety can fuel tremor, that we think that improving the anxiety with CBD can improve the tremor secondarily. So I think that those are reasonable to try at low doses, actually pretty early on. I don't think they're going to be any substitute for levodopa, although not everyone's levodopa will control their tremor. So I think if you do see some improvement in tremor with a small dose of CBD, I think that's something to be capitalized on. I think THC has a little bit more of a risk to it in terms of its risks of confusion and I'm less thinking about long-term risk, but it can make you sort of acutely intoxicated. But CBD has some advantages there, and I think most people tend to tolerate it better than they would the stronger medicines we use for anxiety and insomnia. But I think in a lot of cases they won't be strong enough.
Okay, thank you. Some of us have been following the research on light therapy. Can you give us your thoughts about that?
There are different kinds of light therapy that have been studied for Parkinson's disease, and I think of the different kinds of light therapy that have been investigated, some have better evidence and some have, I think, more tenuous evidence. The kind of light therapy that I think has the best evidence in Parkinson's disease is bright light therapy. And it's not even really for Parkinson's disease holistically that I think you see the best benefit. I think it's specifically for sleep disruption, for disruption of the circadian rhythm. And that is also not unique to Parkinson's, but Parkinson's disease commonly causes sleep disruption. So I think that's why it gets some interest in people with Parkinson's, that it can help with getting people back onto a more natural sleep schedule, particularly as the winter months go on, and sort of helping people to get that light therapy. We've seen similar improvement in mood disorders, so anxiety and depression, especially different times of year. Where I think it's a little bit hazier is sort of the red light therapy, and red light therapy is one of these things that's being investigated for everything under the sun, in hopes that it can improve the activity of the energy producing parts of the cells, the mitochondria. I think the evidence hasn't been great sort of clinically and how people do. The good news, I don't think it's a harmful therapy people can try, but it is a rather expensive therapy. You know, these red light therapy devices that are sold, they usually range from $500 to $1,000 to $1,500. And I think the evidence isn't great that they cause clinical benefit, even though it's an area that they're researching.
Okay, thank you. Next question has to do with when might a neuro-ophthalmologist be helpful? Some of the members have spoken about their difficulties in reading. Their eyes are changing, it seems. So when would you recommend follow-up with a neuro-ophthalmologist?
I think vision problems in Parkinson's are also a little underappreciated, although they're also a frustrating aspect of the disease. I've had very few patients who reported some improvement in their vision with levodopa. That's pretty unusual that sort of Parkinson's medicine actually has an effect on that, and theoretically it would make sense that it could, because the focus of your eyes is done by a very small muscle. So the thought is that treating your Parkinson's disease would allow you to have better control over the ciliary muscle that focuses your lens, but usually it's not that easy. Where a neuro-ophthalmologist, I think, is the most able to help is not so much if vision is blurry, but more that it's double. Because that is something that's more likely to be responsive to an intervention with changes in glasses. But the blurry vision, I've been disappointed by the ability for the neuro-ophthalmologist to have a solution for improving that blurriness. A lot of times they'll attribute it to dry eyes and recommend eye drops, which can have some benefit. Dry eyes is very common in the population in general, but particularly in people with Parkinson's disease. Sometimes they'll recommend some changes in glasses, but I think where they really shine is being able to make that distinction between, it's actually not so much blurry vision, but it's double vision, and I can give you prisms to bend the light back together so you can see again. So the first thing that they do is they evaluate exactly what the changes are, what both sort of how you perform on tests, but also what your vision looks like. Sometimes they can actually see irregularities in the way that the eyes converge together, and that can guide them to a treatment. A neuro-ophthalmologist will want a patient to have seen an ophthalmologist first to look for more garden variety things. If it was just purely a refractive problem that people often get, they don't feel that they need to get involved. But once someone has seen an ophthalmologist and the ophthalmologist doesn't see anything that they can intervene on, in particular if they see something that would require a neuro-ophthalmologist, it's reasonable to see one. We have two on our staff who are in Connecticut. They're in Hartford, unfortunately. I was able to find somebody in West Springfield. I don't know if that's dramatically closer, but I do. You know, I had a hard time finding someone in Western Massachusetts sort of closer than that. But that it might be worth it if you have that symptom.
Yeah, just thinking about access to medical care, and I think as a group, we know that there are no movement disorder specialists in Berkshire County. And one thing that my wife and I have appreciated has been your referrals to like a neurogastroenterologist. I didn't even know they existed. And that person that you gave us, referred us to, has been dramatically helpful. And so there are neuro-ophthalmologists that you could also refer people to.
Yes, Jim. We have the fact that we have them is important. It's disappointing and surprising actually that there aren't more providers in this area. But you know, I was even trying to find a place to get my oil changed, and I had a hard time finding that in this neighborhood too. So I think, you know, some things aren't so easy to come by out here. But I think I'm aware of some people in sort of Eastern New York and sort of along in the line through Central Connecticut. I wish that there was somebody a little bit closer to here.
I think that, first of all, at this point, I think with the rest of the questions, I think you've touched on most of those already. Before we begin closing out this part of our conversation, are there any other questions that have come up for people that you'd like to ask Dr. Dorfman?
Yes, we have a question.
Parkinson's and neuropathy. Is there a connection to them?
Neuropathy?
That's another good question. I think our understanding of this is evolving some. People usually don't have sort of clinically noticeable neuropathy. And yet we're finding it's more and more common that people will have some subtle neuropathy sort of that we weren't aware of. I think neuropathy is just common in general. There are plenty of people without Parkinson's who get neuropathy. But we're finding more and more that there's a subtle amount of neuropathy. And actually that's something that we've been using diagnostically. So for example, this multiple systems atrophy related condition that's distinct from Parkinson's can look so similar to Parkinson's, but they're actually finding if there's a presence of neuropathy, it's more predictive and diagnostic for Parkinson's disease than that cousin. It makes you less likely to have that other disease. But more often than not, the amount of neuropathy you get associated with Parkinson's disease is not very strong. And makes you think that if you do have some stronger neuropathy, is it more likely to be from something else? Is Parkinson's sort of only a small part of the contributing factor? We think that something we're probably not appreciating so much is that there are some vitamin deficiencies that may go along with Parkinson's disease. And what's even more worrisome is that we think levodopa may actually worsen some of that. So there are some people who are looking into adding vitamin supplementation along with levodopa to help sort of combat that. I've also seen that go too far too. We worry about so-called vitamin B6. So if someone's vitamin B6 deficient, we should supplement them because their levodopa is making it low. Well, high vitamin B6 can cause neuropathy too. So there are, it's actually kind of risky to hyper supplement somebody for B6 unless you have a really good reason to do so. So it's not standard practice to treat those things, but I think that there's a degree of neuropathy we think is for Parkinson's, but it shouldn't be thought of as a usually a big feature of the disease.
Does it change the way we treat the Parkinson?
I wouldn't expect it to change motor progression of sort of those motor symptoms, but neuropathy can be something that contributes to your ability to move. You know, I think you can't sort of wash your hands of the neuropathy. If the neuropathy is, say, interfering with your balance because you can't feel the ground below your feet, even if that's not Parkinson's, or even if it is Parkinson's that's contributing to it, I think ignoring that might sort of leave you less functional. So there's this new treatment that we've been using for people with really bad sensory deficits in their feet. That's a prosthetic sensory device called Walkasins. And you wear this insert in your shoe that detects which direction and which angle your foot is at to give you feedback through sensor or a little vibrating attachments that go on your ankle as a way of trying to give you prosthetic nerves it's not as it sounds more sophisticated than it is, but the goal is to allow you to regain some function where if you really can't feel the ground below your feet and it's contributing to your balance, if we just allow you to have some of that feedback through this device, it's something I only became aware of within the past year, but I have had some people without Parkinson's who did see some benefit from it. And insurance covered it.
Thank you. And Jim was next.
I read in the Science magazine today about an ultrasound treatment that's pretty new, I think, and I know they're doing something in Oregon. Are you aware of that?
The one that I think of is sort of really taking off. It's called a focused ultrasound or MR guided focused ultrasound or high intensity focused ultrasound. And it's a powerful structural brain altering procedure. It has a pretty limited utility right now. It's really interesting you should say that. We actually have a meeting with the company that makes that device tomorrow, where we're going to learn about some sort of cutting edge data where they're trying to investigate new uses for that. So that treatment actually, I think even before it was used for neurologic conditions, was used in oncology in a different way. They would use these focused ultrasound beams to not make a lesion in the brain, but to open a small sort of microscopic hole between the blood and the blood-brain barrier to allow chemotherapy drugs to come through. So it was kind of an interesting idea for that, but the goal wasn't to make a change in the structure of the brain. It was just to lower the defenses a little bit to allow chemotherapy to get in. So that was a neat early utility for that treatment. In Parkinson's, we use it to kind of go back to an older treatment that we did for tremor, because we've known for a long time that if there's a tremor circuit, and if it's necessary and you're motivated enough to do it, you can stop a tremor by just damaging the circuit intentionally. What they would do originally, they would take an electrified rod and they'd burn a hole mechanically through an open surgery called a thalamotomy. I think Michael J. Fox went for a thalamotomy. And then that was sort of the birth of DBS, as it turns out. Because while they were doing that procedure, burning the hole, even before they actually made the hole, just turning the electricity on stopped the tremor. They said, well, do we really need to burn a hole? Could we just leave a pacemaker in there and just give you pulses of electricity to do the same thing without making a lesion in the brain. And then they turn that into a treatment, they turn that into DBS. And we've been doing DBS since the 90s, but this ultrasound treatment has come back into vogue as a way of doing that old procedure, the thalamotomy, but they're able to do it without opening your skull. So at present, it's really only used for tremor in Parkinson's disease. Someone doesn't have any tremor, we don't even think of doing this procedure. And what we like it for is it's another option for doing something similar to what DBS can do for tremor, but doing it less invasively. So instead of having to implant something in the brain through a multi-stage, overnight stay in the hospital surgery, you can get the whole thing done in 3 hours and go home with immediate improvement in tremor. So that's, I think, what it's nice for. Personally, I feel like DBS is still a more powerful procedure because it's not just a one-trick pony. But this whole talk tomorrow is about, their new research into, well, what if they can use this ultrasound for things besides tremor. There is, as it turns out, an indication for motor fluctuations for that treatment. I've never seen anyone actually use it. And I would worry about how well that would work, because Parkinson's changes over time. It could change over months to years. If you go for that treatment, how long can you really expect the benefits to last? I think the tremor circuit is a less sophisticated, more well understood circuit. I think it's easier to get lasting results with that procedure for tremor. So I think that's why it hasn't really taken off for treatment of anything else with Parkinson's, but they're investigating that. So the PTT target is the new target they're investigating. So it's funny, we're actually gonna have a meeting tomorrow to learn about what their research is.
Thank you. Janice?
Yes, I have a question about the Crexant. If you're a person who's already having DBS but you're also taking the carbidopa, is it a benefit to switch to the Crexant as far as when you already have DBS, it's just more sustained?
Anything goes. I just this morning, I had a woman with DBS who had put on one of those subcutaneous pumps. And we used to think of those as sort of mutually exclusive. You go for a pump or you go for the surgery. And usually not in that order. Usually you say, oh, I went for the pump. It wasn't enough for me. I had to go for DBS. She's somebody who went for DBS and it helped it a lot. But rather than really just double down exclusively on the DBS, there were advantages to using the pump concurrently for her. So the same as goes for Crexont. If you're still taking levodopa with your after DBS, there's no reason you couldn't use Crexont as your levodopa.
And would the Crexant have less possibility of dyskinesia side effects?
I found that for some people they do get away with less dyskinesia.
Okay.
Just because it doesn't spike quite as much. It still can cause dyskinesia, but I think even though they don't advertise it that way, I find that it has a lower rate of it because you're able to use less of it and use it less frequently.
David?
Yeah, that's where I'm talking about DBS. I get a question. What's the difference between DBS and adaptive DBS? And how do you choose one system over the other for your patients?
Adaptive DBS is just a new feature that's offered by one of the manufacturers. It's a new special way of programming that they offer it as a new technology. They've got a really good marketing team because the word really got out about that. There are 3 manufacturers who make the devices. And I think different providers have different allegiances to different ones based on which features they have. And I think you can do similar things with the different devices, but some of the new features that have come out have made some easier to use than others. So it's as simple as that. It's if sort of there's a feature that makes somebody easier to program or sort of quicker to program, that may be enough to tip the scale and say, this is the device that makes the most sense. Patients shouldn't really feel such a difference from one device to another. You should be able to do similar things. You can reach all the same settings, but there are these subtle differences between one and another. And adaptive stimulation is proprietary technology of one of those manufacturers, but it is unique. They're the only ones that have something like that so far. And it's the first step towards something we've thought about conceptually for a while, which is called a closed loop system. The current state of things before adaptive stimulation was you go to the doctor's office, we program your settings and you go home. And sometimes we give you a little leeway where you can increase your settings to if you need to within a limited range in one of the settings. What adaptive stimulation is we can give your device parameters and it can listen to your brain and make its best guess what you need in that moment. And we'll, on a short leash, you know, we give it instructions for what to do, and based on what it's sensing inside the brain, what it feels like is going on, it tries to adjust your settings. So I think this person's having a lot of tremor right now. I'm going to increase the settings. Oh, this person has a lot of dyskinesia. I'm going to lower the setting. And it's a way of trying to give somebody more even control of their symptoms, because we know the disease fluctuates over the course of the day. And it would make sense that sort of adjusting your stimulation would be helpful. How important or how sort of clinically relevant that is up for debate. I've done it in some people who saw some benefit. For other people, is it really any better, or is it just a gimmick? I think it's definitely nice to have the capability. That's one of the things I think leads people to choose that company over another, just to have it in case you want to use it in the future. And they have a great device, so I like their device. But as to whether or not the adaptive stimulation is as much of a game changer as they advertised it, a little controversial. When they came out with their big media push, they said that it was FDA approved as this breakthrough. The FDA approval was that the battery worked. FDA didn't comment on whether adaptive stim helps. So they actually had to, the other manufacturers, I don't think they formally sued, but they pressured them to change their website.
So one of the three different devices are different enough that would work for one patient, another one for another patient, or?
In limited cases, I more often than not, no. I think there's a colleague of mine, she's leaning towards one over another because it has a better battery life than the others. So I think that makes sense for someone who maybe we already know that they're going to need a lot of battery life, just although you usually can't predict that sort of thing, but somebody who's had repetitive battery replacements, you know, if the battery only lasted a year, oh, that's really frequent battery replacements. Should we go with the one that has a substantially longer battery life? That would be a reason. Or there was one company that has remote programming where you can program someone with them sitting at home without even going to the doctor. During the pandemic, I think that would have been taken up in a big way if they hadn't missed the boat by 2 years. So I think these features are helpful, but they're usually not. I think it'd be like a limited case where I'd think of someone this really has got to be the best one.
Let's go to maybe one more question. Wayne, you have a question, and then I want to introduce Jamie, your assistant, your medical assistant. I think she's still here. But she's going to come up front for a moment. But Wayne, let's hear your question first.
In reference to neuropathy, I've only had Parkinson's diagnosed for a couple of years. Neuropathy I've had for 25 years. I'm at the point now where I have to use a walker, and I can't, you know, I have no balance, no nothing. I'd be very interested in what you spoke of as far as that. I can't remember which.
Yeah, write it down. Walkersons.
Yes, how can I find out about?
They are a private company. As far as I know, they're the only company that has a device like this. And I think other things that have been attempted out there to try to help with neuropathy have been electrical stimulation therapies done by physical therapy offices, and I think that those are, when they work, they're really better at reducing pain or tingling or something like that, but less good at sort of restoring sensation. That's been such a burden. Wouldn't it be lovely if we could cure sensory ataxia? This is the first that I've ever seen of as a treatment that is supposed to allow you to accommodate for that symptom.
Maybe I can help. Maybe afterwards I can get their website.
Yeah.
And get that to you, Wayne. So I think that we're going to get to the point now where we break into two groups, but before that, we're going to hear from Jamie, and I want to introduce her in a second, but I think both Jamie and Dr. Dorfman are going to stay with us for the second hour. So they'll rotate between the two groups, so there'll still be a chance for you to interact with questions as they flow through. But before, I'd like to introduce Jamie, Dr. Dorfman's medical assistant. One of the things that Dr. Dorfman and Jamie have provided, all of you, I think, have this sheet on your chair. you've heard not only of Dr. Dorfman's expertise, but the fact that he's accessible in Torrington, which isn't far away. You don't need a passport to go across the border to Connecticut. And to hear about colleagues, not only are you a movement disorder specialist, you have a whole group of movement disorder specialists. It's with a group called the Chase Family Movement Disorder Centers. And it's one of the most comprehensive centers in the country. So it is accessible here. And those who would like to consider asking Dr. Dorfman to be their doctor, this sheet gives you step by step what needs to be done in order to see if that's possible. Jamie.
So first step would be to speak with probably your primary care doctor. We will accept new patients on a referral basis. So they would fax over all of your relevant medical information. So that would be your progress notes, any imaging, lab work, things of that nature. Once we have your referral, we would then reach out to you directly to schedule. If you didn't hear from us within a couple of weeks, you could always reach out and then we would be able to schedule you from there.
Okay, so this sheet, I think step by step, and there's also a phone number on here to call if things are getting more complicated and you need help. Ivona Golas, I think, helped to put some of this together.
Yep.
So anyway, if you'd like to see Dr. Dorfman, it's possible. There's the way to provide access. I'm just blown away by this man's expertise. Let's give him a big round of applause. So thank you, and thank you, Jamie. And so what we do is people who are care partners, Bob over here is our facilitator for that group. We go out this door, take a right down to the end of the library. There's a gathering place there for us. People with Parkinson would stay in this room. Tried to sort of figure out how to circle up the chairs, but we'll figure out how you can do that. And between Jamie and Dr. Dorfman, maybe if you want to stay here for the first half hour, or the first 20 minutes, probably a little bit shorter, and then Jamie can come back with the other group, okay? So thank you.
Thank you for having me.
For those who are online that want to stay in the conversation, you'll need to unmute yourself. And for those who are with Parkinson's and want to be a part of the conversation in the room here, unmute yourself and you can participate.
They sort of do. We'll use that.
Back here is.
Yeah.
Are you ready?
Are you gonna stay put? I'm not. I was trying to figure out. I don't know if I stay put.
No, you have to.